This week on Part 2, we continue our insightful conversation with Dr. Malani, diving deeper into his expertise in gastroenterology, nephrology, and chest medicine. From managing chronic conditions to understanding key advancements in these fields, there's a lot more to unpack.
You specialize in gastroenterology, nephrology, and chest medicine. Can you just help our viewers and our listeners understand why these areas are so important to our overall health, especially here in Fiji?
Yeah, thank you. Again, one of the important aspects of postgraduate training was also to improve clinical skills and procedures to be keeping in with the specialist training. I not only saw great lack of skills in gastroenterology, chest, and renal medicine, but they were all in other specialties. I did other things apart from all those things. Probably the first pacemaker that was put in Fiji, I put in myself. I was sort of probably like a cowboy when I come in. There were things that needed to be done. I just did it because I had done it in my training in New Zealand. And that's one of the things that I've always told doctors, that when you go away for training, you must come back and upgrade and impart your knowledge when you come back. And that's basically what I did. I saw the need when I had, and I did it through my doing of the postgraduate training. And the first HIV case that was diagnosed in Fiji was me. And it was a Tahitian lady that was here. And the rest is history. So these specialties you're saying are crucial because they address some of the most vital systems in the body, for chronic digestive systems. In Fiji, rising obesity, currently at about 30%. They also associated with gastrointestinal issues. In nephrology, it's increasingly significant given chronic kidney disease affects approximately 14% of Fijian population, often linked with diabetes, which raises the prevalence rate of about 60% in adults. Chest medicine remains vital, as respiratory infections are among the top 5 causes of morbidity in Fiji and affecting thousands annually. Now, gastroenterology, just to come back to some of those ones, I had great interest in gastrology. I did gastrology in New Zealand. I was doing diagnostic and endoscopy before I came here. When I came here, Dr. Al and myself, two of the oldest physicians here, are able to do gastroenterology. But it was only diagnostic. By that, it means we can only have a look. We can't do anything more. But now, after having had what we call a World Gastroenterology Organization, and so SUA in here, we have a world-class gastroenterology center, and a lot of people don't really know that. Our standard is probably as good as if you were to go to Australia and New Zealand. Prior to 2008, and that's when we established the gastroenterology program here, we had very limited skills. We could not do colonoscopy, which is looking from the large bowel from the bottom, and definitely no interventional endoscopy. Even people had to be referred abroad for colonoscopy and variceal banding for varices. Now people here will look at it, wow, that was the state at that time. And we didn't even know what were some of the things that were hiding inside our large bowel. Now we're really starting to see things that we thought we never had it. Back then in the 2000s, cancer of the stomach was one of the commonest causes when we were looking at in Itoke people. But that has changed quite a lot, I think, with the treatment of H. pylori and all those things. That has changed quite a lot now, so that we still see them, but we don't tend to see a lot of. So it was through Professor Finley McRae, is really quite an outstanding professor who amazingly came in and we started the program. And now over 40 to 50 nurses around the Pacific have gone through the training. In fact, it's much more, and that numbers there. We can do diagnostic upper and lower endoscopy, and we can even do a more complex one called ERCP. So this program is really quite amazing. We wrote that they will not support chronic dialysis. And I believed in that because we didn't have the money to support a chronic dialysis program. So, but I went outside and together with private people, we raised funding and, particularly Dewan Maharaj, the late Dewan Maharaj, and may his soul rest in peace. So now we established the first dialysis unit after 7 years of fundraising. Yeah. So initially it was to support people wanting to go for kidney transplant, to give them a second chance. But once it started, it became quite obvious that the majority were people who wanted to be on chronic hemodialysis. So this was able to use the motto, give back a gift of life. That's where it came from. So that's our motto at the Kidney Foundation, to patients, and even allow people to go abroad for kidney transplant. So now it's almost like normal conversation now, dialysis, kidney transplants. Back then it was death sentence. We were also able to shift hemodialysis unit to the intensive care unit, and the mortality of patients dropped from 80 to 100% to below 40%. In those days, if you enter kidney to the intensive care unit because you're sick, your mortality was about 80 to 100%. So with the introduction of acute hemodialysis, we dropped that down to about 40%. So up until then, it was all peritoneal dialysis. They would put a sticker tube down your tummy and they would wash your water in and out to clean your blood. It was quite messy and the nurses hated it in those days. So this was another exciting thing in my life, transforming lives of patients with ESKD. Now there are about more than seven hemodialysis centers throughout Fiji. But we're only able to dialyze 20 to 30% of the 700 to 900 ESKD patients that are coming out of the woodworks every year. So it's still a death sentence to about 70% of patients. My regret, and I'm running out of time, is working on the preventative aspect of ESKD, especially diabetes. I know that our NCD system and the National Society of Nephrology have been working up something. In the immediate and long term, we must address these issues because the future is now. Yeah.
Thank you. It's quite inspirational, especially getting that insight. For someone who's worked in New Zealand and in Fiji, how would you compare the healthcare challenges and the needs in the Pacific region?
Yeah. And again, it's a long, big question. So the Pacific region represents quite a diverse landscape of healthcare challenges, and in every island, Australia and New Zealand are advanced country healthcare systems, and Fiji and Pacific Islands are developing countries. Like in New Zealand, approximately 80% of the healthcare system is publicly funded and ensuring broad care to services. But despite that, there's still disparities exist with the Maoris and Pacific people experiencing 25% higher rates of hospitalization for preventable conditions. In Fiji, the healthcare expenditure is about 4% of the GDP compared to New Zealand, 9% of GDP, leading to, and you can see the resource constraints. So that's already you can see. So the biggest amount that it is reflecting medicine in a developed country versus a developing country like Fiji. A lot of our problem here is we just don't have the fund to fund programs. Yeah. On paper, we have probably one of the best NCD programs, but it doesn't function because it is not being put into use. There's no money to run preventive programs.
Tune in next week for part 3. We continue our conversation with Dr. Malani, focusing on the rising concern of kidney disease in Fiji. We'll explore the early warning signs, prevention strategies, and how you can take better care of your kidney health. Don't miss it.